Happy July 7th, everyone in EMRAP land. Swami here, as always, with Jan. Jan, how you been?
I am so good, my friend. How about you?
I got no complaints at all. And to kick it off the week, I've got a tiny little fact that I'm going to throw at you. All the way back in 1958, on this day, Dwight Eisenhower signed Alaska Statehood Act, and that made Alaska officially the 49th state in the U.S. Jan, I haven't been to Alaska. You been before?
I have been to Alaska only once. I spoke at a conference at the Alyeska Resort, which is this beautiful ski resort outside of Anchorage. We were there in the summertime, so it wasn't actually ski season, but you could still take the, gondola to the top and look around, and it was really beautiful. But did you realize how big Alaska is as a state? Like if you look at overlays, where they take, the map of Alaska and they lay it over the center of the country, it covers a huge territory. It is more than twice the size of Texas. I mean, if you start looking at the stats for how big the state is, it really is impressive. So I think there's a lot more to see than one ski resort is my point. I have a lot more of Alaska that I would like to experience.
I have a feeling you're not going to get to all of Alaska, but that's okay. I think you've already gone somewhere that probably most Americans have not been. I'm really excited to go. I really want to go to Denali. I really like to check out kind of like maybe like a cruise along the coast of Alaska, which I heard is absolutely beautiful. Someday down the line, it is on my list.
Yeah, go before all the icebergs are gone. I mean, I think that's, part of the goal for most of us is we'd like to actually see an iceberg before they disappear.
All right, before the icebergs melt, but before we get into the rest of the show, Jan, I do have a case I want to kick off with. You ready to dive in?
I am ready.
All right, I've got an 83-year-old man who is coming in by EMS with weakness and recurrent syncope. He's got a history of hypertension, hyperlipidemia, coronary artery disease with 3 stents. And when he rolls into triage, his heart rate is somewhere around 200 beats per minute. His blood pressure is 114 on 60. O2 sat's fine at 97% on room air. He is afebrile. They bring him back to me along with the ECG, which, Jan, I'm showing you his ECG right now. What do you think?
Well, I'm looking at this ECG and it's fast. You said it was 200 and it looks a bit wide. It looks regular. There's 2 numbers in this whole scenario that I really don't like, and that's the age of 83 and the heart rate of 200. Those 2 numbers just do not jive with me.
Bad combination.
I am not comfortable. I don't care how good he looks. I mean, I'm hoping he looks okay. The blood pressure tells me he probably looks okay, but is he confused? I want to know about perfusion. I'm clinically interested in how this patient looks, of course.
100%. So you nailed the ECG. It's wide, it's regular, it's fast. The listeners can check that out in the show notes if you want to see what this guy's ECG looked like. And as we're kind of looking at the ECG and looking at the patient, we're trying to narrow down our differential. The differential for fast, wide, and regular is pretty short.
It is very short. And for me, it begins with 2 letters, which is V and T. But, there is the SVT with aberrancy that you learn about. I always have hyperkalemia on any of these differentials. Potassium could do so many weird arrhythmias. I'd always want to know the K pretty early on. So those are kind of the top of mind for me. How about you?
100%. I have talked to Amal about this so many times, and it's VT, VT, VT. And then I guess you can consider SVT with aberrancy if you really want to. I think you have to have hyperkalemia in there, especially if the rate was maybe a little slower, like in that 120, 110 range. You got to be thinking about hyper-K. This one's a little bit too fast, probably. And I guess if you want to throw in one other possibility, maybe it's flutter with a bundle branch block. I guess that's a possibility too, but I guess we can lump that in with SVT. Here's the big question, Jan. Does it matter which one of these it is, whether it's VT or SVT with aberrancy?
This is one of those neuronal connections that I've managed to maintain over all these decades, which is that it doesn't really matter. Just default to VT. Of all of those rhythms that we've just talked about, the most dangerous one is ventricular tachycardia. And the reason is, and it took me a while to actually ask this question, why do we just default to it being VTAC? Why do we do this to ourselves and just, say to everybody, just treat it like VTAC? And that's because VTAC is very dangerous. You are going that fast in usually a diseased heart, you are at any point prone to sudden cardiac death, degeneration into VFib. It's just not a rhythm that generally can just sustain itself for too long, especially in an 83-year-old with terrible heart disease. So I think that's the reason that we say assume that it's VTAC because it could go south very quickly if you don't deal with that.
I think sometimes people don't realize that until you've seen it once or twice. VT becomes unstable VT, becomes VFib, becomes dead. And it is just a matter of time. And the longer that we take in trying to figure out what this is exactly and exactly how we want to treat it, the worse it is for the patient. But again, Amal and I have discussed these in the past. There are all these different algorithms that you can use to try and figure out, is this VT? Is it SVT with aberrancy, like Brugada? And there's the Basel criteria. Jane, you using any of these in the clinical setting?
No, in the clinical setting, not honestly, no. It's the kind of thing that when you're in conference, you're in resident conference or you're teaching about this, you talk about it. It's sort of it's a mental exercise of understanding the different rhythms and the EKG tracings. But at the bedside, I am not using those things because as soon as I see that rhythm and I'm thinking VT, all I'm thinking about is the patient and what I'm going to do about it. I'm not going through the exercise of running through these different, scenarios and different theories about what it could be. So no.
100%. And that's exactly where I fall. That's where our team fell when we were taking care of this patient. We decided this is most likely VT given the patient's age, what it looks like. He's got an underlying history of coronary artery disease. All of this feeds towards being most likely VT. So knowing that or accepting that this is probably VT, I'm going to treat it like VT. Is there anything else you really want to know before you move forward with treatment? I'm going back to the patient. I do want to know what the patient looks like. I want to know what the perfusion is because obviously when you're in your mind of this algorithm, you're in that stable, unstable question mark area about what therapy I'm going to pursue. So it goes back to the bedside and how am I feeling about this patient? And what are my resources, I guess? Where am I working? Sure. I mean, he looks okay. Honestly, he's awake. He's talking to us. He doesn't look comfortable. I wouldn't say he looks like a comfortable patient, but his heart's going 200 beats per minute. I don't think he should feel very comfortable. He's maybe a bit pale, a bit sweaty, but overall, he looks okay. So I guess I would call him relatively stable, pseudo-stable, if you will.
I love how you're painting this picture where it could still go either way. Like, of course, we're all thinking about
toeing the line, Jan, toeing the line.
Versus, you're just painting the perfect picture of like, do I want to shock this patient or am I going to use a drug? And you're telling me elements that push me both ways. So I'm really on the fence at this point.
What would you choose? I mean, given this scenario where the guy's awake and talking to you, but he is 83 and he does have a rate of 200, would you go right for the paddles or are you going to ask for a chemical first?
So personally, my choice would be electricity. Again, I see this 83-year-old, 200 beats per minute. I want to take care of this now. I really don't want to futz around with ordering a drug, the nurse going and getting it. I would probably choose a drug that they may not have readily available. So I'm going for electricity. That is what I'm most comfortable with in this scenario. I just want to terminate this rhythm.
Well, let's talk about those drug choices because you said the one that you would probably ask for may not be readily available, or maybe your nurse isn't as comfortable with that drug. So if you were going to go with a chemical, which agent would you be selecting?
So I'm thinking about procainamide as my choice. That's one that I am comfortable with. And I know it's very effective for this particular rhythm, but it's not going to be that quickly accessible for the nurses. It may not be one that they're super familiar with. It may take a while to set up the drip. The pharmacist is probably going to have to be involved. So in my mind, that's all going to take time. Even if I chose amio, to be honest, it probably still would take some time.
And I think if you're going to go with a chemical, based on what's usually available in emergency departments, procainamide, amiodarone are going to be your big choices. I guess lidocaine is in there. And the Procameo study, we've talked about this many times in the past. It's probably now about 8 or 9 years old. And it showed that procainamide was far superior to amiodarone. I think there was like a 15 or 20% difference in the efficacy rate. But the thing that kind of stuck with me was that procainamide was way better, but it was still only effective about like 60% of the time or 65% of the time. I'm like, so you're telling me 4 out of 10 times that I give procainamide, the patient's not going to convert. And I don't know, Jan, it's not just that we have to assume the worst. We also have to treat the worst quickly. And I don't know that I like a 60% success rate. So I like using chemicals and I love procainamide, but I think I'm going right for electricity here as well.
Yeah, I'm definitely going for electricity. I'm thinking about, are the pads on? Where is the thing? Let's get the sedation drug. We got to pick that, all that kind of stuff.
So we decided as well that we're going to go straight to electricity. We kind of warned the patient. And as we're getting the device out, we're putting the pads on. Would you typically go AP or AL with your pads when you do this?
Ooh, such a good question. If I'm putting the pads on de novo, I'm going AP. Often the pads are already on, and if they're on an anterolateral position, I'd probably be okay with that rather than peeling the pad off this poor patient and plopping it on the back. I'd probably be okay with the anterolateral vector, but I prefer the AP vector.
All right, I prefer AP as well, and that's what we went with. We went right to 200 joules, and Jan, we've talked about sedation agents in the past. I like using etomidate here. I think it's okay if you wanted to use propofol instead. I just like the fast on, fast off with etomidate. So we went ahead, gave this guy 0.1 per kilo of etomidate, gave him one shock at 200 joules. And this is cardioversion because he does have a pulse and a pressure. So we did synchronize this and he came right out of it. One shock, he was out of it. He clearly felt better and the sweatiness was gone. The paleness was gone. So we all felt a little bit better as well. And then we called cards and we admitted him to the CCU on an amio drip. Kind of a pretty run-of-the-mill emergency medicine case, Jan, but there's lots of little nuances in there as you go through it.
There are a lot of little nuances. You're right. It's sort of a standard case, but to think through why you do each thing and why VTAC is so concerning and how you analyze it, I think is worth reviewing. Cardioversion is one of those procedures that's so enjoyable, in the sense that you push a button and get a result. How many things do we get to do that for? Not that often.
Right.
That is a good. It is worth noting, and you just mentioned it, that as this patient got admitted to the CCU, they still put him on an amio drip, despite the fact that he was not in an arrhythmia anymore. So you still, obviously this is someone who's still going to a CCU at this age and being put on a prophylactic antiarrhythmic and then obviously getting workup for his coronary artery disease and what precipitated this, I'm sure.
Right. And of course, you got to repeat the ECG after you convert the patient, make sure there isn't a STEMI going on or something that needs cath lab activation. We, of course, did all of that, decided he didn't need to go right to the cath lab. Although they did take him the next day and they did place a stent, but he clearly did not have an acute need, an immediate need to go to the cath lab at that time. And so, Jan, when I look at that case and I teach my residents about these kind of cases, there's a couple of things that come up that I think have to be hammered home. The first is that if you see wide, narrow, and regular, it's ventricular tachycardia, it's ventricular tachycardia, it's ventricular tachycardia. And while there are other options, just treat them all like ventricular tachycardia, because if you're right and you treat it as ventricular tachycardia, the patient does well. If you're wrong and it's actually SVT with aberrancy and you treat it as VTAC, the patient's going to do fine. But the reverse doesn't really work. If you assume it's SVT with aberrancy and it was actually ventricular tachycardia, you could do some harm to that patient. So that's why we assume ventricular tachycardia, treat it, let somebody else figure it out later. The algorithms just aren't that good in the clinical setting. They take way too long and they're not that accurate. And Amal has said this many times before as well. They just don't perform as well as you'd like them to. And if you have decided it is VT, you're going to go down that treatment algorithm. Electricity is the safest and most effective by far.
And if your patient refuses electricity, which every once in a while one's like, you are not going to shock me, then pick procainamide. That's the better of the two choices based on the evidence we have.
100%. Or you distract him and then shock him while he's distracted. It's one or the other.
So look over here. Yeah.
Oldest trick in the book,
Love
Jan.
it.
All right. So ventricular tachycardia, great case to kick it off with. We've got some really interesting things this week. We've got a segment on the /trach where Eileen sits down with a peds ENT doc. And this really is springing from the segment that we did with Justin Morgenstern last year, talking about the fact that a needle airway in a pediatric patient is not always your best bet. And we probably should skill up and learn how to do one of these /trachs. So we've got a great segment on that. We've also got a segment with Mike Weinstock talking about risk management, kind of kicking off a little bit of a curriculum that we're going to have on the monthly for the next year or so. But Jan, before we get into those segments, we're going to hit a couple of papers from EMA, and I'll see you on the other side.